Good morning, good afternoon, good evening, clinical problem solvers. It's Tuesday, neurology morning report. Happy to see everyone to discuss a neurology case today. And you know the routine, we need two discussants. We actually have a case already. Two discussants, ideally one identifying as a woman and one identifying as a man. Do we have volunteer discussants for today? Who would like to discuss a neurology case? I do as you know, first Tuesday of every month, I have a 10 o'clock meeting for my actual job. So I'll have to finish on time. So if two people can volunteer to discuss the case, that will get us started on time. Because if it's a case from Kirtan, we know there's going to be a lot to discuss. Who would like to volunteer to discuss case today, neurology case? Maria is making a plug for it as a many-time discussant and big fan. Valeria is making as another many-time discussant and big fan. They're going to be helping us out with scribing and teaching points. You might be thinking, oops, I thought it was some other subject. It's neurology. No way. That's a great reason to join, actually. You'll then get to talk through a neurology case, a fun, safe environment, learn some neurology. You might be thinking, English isn't my first language. That's okay. We have French speakers, Spanish speakers, Portuguese speakers, everything speakers. Vivek, Paul, thank you. Fantastic. We have one discussant. Can we have someone to discuss with Vivek? Second discussant, please, please. Who would like to join myself and Vivek and Kirtan discussing a neurology case this morning? All right, we'll do our usual trick. Kirtan, Vivek, if you'd like to introduce yourselves, and that might inspire someone to be a third discussant.
Yes, so good morning, everyone. Myself, Kirtan Patolia. I am a final year medical student from India, and I'm looking forward to applying for math this year. And I'm always, busy with paperwork. But I think that Neuro VMR is one of those moments where I have to present so that I can understand and learn more and more. So excited to be here, and I'm looking forward to present a case today.
Fantastic. And while you were introducing yourselves, Hannah has come on board. Thank you so much, Hannah. So Vivek and Hannah, so excited to discuss this case with you. If you don't mind introducing yourselves, and we'll get going.
Hi, everyone. Good morning. I'm Hannah. I'm zooming in from Arizona, fourth year medical student.
Fantastic. Vivek?
Hey, so I'm Vivek. I'm a medical graduate from India, and these days I work as a research assistant in neurology, actually, at Northwestern University. So hopefully I can do justice to my research training here.
Fantastic. Great. All right. So I think everyone, names look pretty familiar. If you haven't been here before, we'll hear Kirtan present this case in very small bits and pieces, and Hannah, Vivek, and myself will discuss each piece and try to reason our way through and see what happens. So great. Kirtan, would you like to tell us, I know you had a title for this case to intrigue us, if you'd like to present that, and we will not try to deduce the diagnosis just from your provocative title, and then after you've given us that, the chief concern, and then Hannah, Vivek, and I will begin discussing.
Yes, sure. So the title is An Elementary Diagnosis. So that's the title. And the chief complaint is weakness in all extremities.
Weakness in all extremities, an elementary diagnosis. Hannah, would you like to tell us how you would start thinking about this chief concern?
Sure. So weakness in all four extremities. I will be curious as to the onset. Is it rather acute versus is it a chronic insidious process? I'll be curious about the rest of the medical history and the demographics. The title saying elementary, I'm thinking it's going to be perhaps an electrolyte disturbance, but I'm not going to let that anchor me too quickly. But I'd certainly want to place this in time and then with the rest of the demographics.
Fantastic. I agree with you. An important component of neurologic differential diagnosis, any differential diagnosis really, is the the tempo, the pace of symptom onset and evolution. Just to take that a little further, Hannah, we're dealing with weakness, which, as we know, is a somewhat general concern, complaint. But on the time course piece for any neurologic presentation, how will you use the time course as it comes out in the history? For example, if you hear that this was sudden versus over hours to days versus days to weeks versus months to years, what sorts of things would you start putting in those buckets?
Yeah, in the hyperacute setting, you're kind of thinking more vascular. So this perhaps is more of a stroke. And then on the complete other side of that, something very insidious, very chronic, you'd be looking, maybe is this a tumor? It'll be interesting if it's symmetric versus asymmetric as well, which might help direct things. And in that intermediate, it might be something like metabolic, which will be more acute. It could be something like an infection, which should also be kind of acute to subacute. So those will kind of place our buckets like that.
Fantastic, great. So as most people here know, I like to frame the neurologic differential diagnosis, so this works in the rest of medicine also, as the localization and the time course. So we're going to have to figure out where in the nervous system this problem is that's causing weakness. And then, as Hannah told us, the time course is going to help us as well. So is this sudden onset neurology? We think of vascular. As you mentioned, this is weakness in all extremities as opposed to on one side. So typical strokes we think of causing hemi sorts of things, although you can have bilateral strokes or midline things or things like that. So, fast, very fast in neurology. Sudden, we think about stroke. Other things in that category, seizure. We wouldn't think of seizure presenting as weakness, but you can have a postictal paralysis. Patient could be weak after an unwitnessed seizure. Toxic metabolic, you mentioned, always on the differential. And element, I thought the same thing. Where on the periodic table are we with Kirtan's wordplay here? Some type of electrolyte or something like that. And then trauma as well can be in that sudden category. Acute, as you mentioned, infections, bacterial, viral, particularly. And toxic metabolic actually fits into all categories. So there could be sudden onset, toxic metabolic drug, acute but not sudden, subacute, and chronic. Other things in that acute bucket, we can think of inflammatory. So things like demyelinating conditions like a flare of multiple sclerosis, or we could think of, if this is weakness evolving over hours to days, we might think of Guillain-Barré, an inflammatory condition in the peripheral nervous system. As you mentioned, subacute, we might think more of a tumor. There's atypical infections in that bucket as well, some inflammatory conditions, and then chronic, we might think of degenerative, right? So I think, as people have heard me say before, right, a lot of people memorize vitamin D and Vindicate and all those things. I found them very hard to remember, but thinking in terms of etiology by time course will help us generate and test hypotheses as we go through this HPI. Fantastic. Great, so Hannah helped us out with the time course piece of this differential diagnosis and started to talk a little bit about pattern of weakness. Vivek, do you want to tell us a little bit about how you might think about weakness in terms of localization?
So yeah, weakness, if it's unilateral, then you can definitely, you're thinking more of, depending on the time course, like you said, you're thinking either of a stroke, hematoma, tumor, something causing some sort of mass effect, or possibly a spinal cord injury. But for weakness in all extremities, like this person has, I'm probably thinking more, some of the systemic things that you described, either metabolic, nutritional, hematologic. Those are probably higher on my differential list when they're talking about weakness in all extremities, or something like Guillain-Barré, ALS, possibly myasthenia gravis, something again that's the autoimmune conditions are more systemically acting, not as localized as something that would present unilaterally. So that's where I'm at with this.
Yeah, fantastic thoughts, Vivek, right? So if this is truly symmetric weakness in the arms and legs, and we'll hear more from the history, whether it started in one place and moved, is it proximal versus distal? So when we think about weakness, one thing that's going to be very helpful is the pattern, right? Is it unilateral? Is it bilateral? Is there anything going on above the neck, right? That tells us brainstem or brain would be involved if there's weakness in the face, above the neck, or in eyes, etc. Or is there only weakness below the neck? And is it symmetric or is it asymmetric? Are we thinking of a unilateral lesion, bilateral lesions, or is Vivek said a more systemic or within neurosystemic, right, process affecting all aspects of one aspect of the neuraxis? So how do we get weak? Well, we have to first decide if the patient is truly weak, right? When we examine them, is there true deficit in strength, or is it a subjective sense of weakness that sometimes is called asthenia, right? That patient just has a systemic illness. We all know this from having the flu or getting sick, right? That you just feel weak all over, but if you really tested your strength, it would still be 5 out of 5. You just sort of feel systemically weak. Presumably it's neuro morning report. So we're gonna have a neurologic diagnosis here, but a systemic process could certainly do this, and it's unclear sort of what, at least to me, what the physiology underlying that is. But if we have true weakness, it means there's some problem with the muscles being activated at full strength. And so how does that happen, right? Well, we have to think of the whole neuraxis, right? From signals from the brain all the way down to the muscles. So our signals to move, well, once we've decided to move and what movement we're doing, the actual signal, pushing send on the email, and the signal goes down to the muscles. That's in the precentral gyrus, right? The primary motor cortex. And then those fibers run down through the internal capsule, through the anterior brainstem, cross at the cervicomedullary junction, run in the posterolateral spinal cord, synapse on lower motor neurons and the anterior horns of the spinal cord, come out through ventral roots, through plexuses, through peripheral nerves to the neuromuscular junction to muscle. So anything on that list is possible when we hear weakness as a localization, systemic illness, or brain, brainstem, spinal cord, nerve roots, nerves, neuromuscular junction, muscle. And Vivek moved us a little bit along the localization already, saying, well, if this is really weakness in all of the extremities, right, it's truly bilateral, you were thinking about things like nerves, neuromuscular junction, muscle. And I agree that that's all correct, right? Because to be weak in all the extremities from a brain lesion, we have to have bilateral brain lesions, right? And if the patient is awake and talking, we're going to find out soon, right? The fact that they are just weak from bilateral brain lesions, that's pretty implausible, right? No sensory loss, no other cognitive symptoms. What about the brainstem? Well, it's pretty small. You could get one lesion getting both corticospinal tracts on the way down, but there's so much going on in the brainstem, right? All the cranial nerves coming in and out, the connections to the cerebellum, et cetera. So to have just weakness, nothing else from the brainstem, pretty implausible. So when I hear weakness in all 4 extremities, I'm really thinking spinal cord or below, right? Spinal cord lesion could do this. The patient would be awake, talking, everything above the neck is working, right? And we'd be looking for other symptom signs, which we can talk about for the spinal cord. Or we could be in the nerve roots, right? But to get bilaterally, the nerve roots would have to have some type of diffuse polyradiculopathy process, which is not that common. And then below that, we could have the peripheral nerves, right? A peripheral neuropathy that's affecting the nerves all over the body, right? All of the nerves, both arms, both legs. We could have a neuromuscular junction process like myasthenia or Lambert-Eaton, or we could have a muscle disease, a myopathy, right? That could be presenting this way. So I think as a first pass, if there's really nothing above the neck, we're spinal cord or below. And so with that in mind, Hannah and Vivek, what sorts of things are we going to listen for in the history that might make you think, oh, that does sound a little more spinal cord versus that sounds a little more nerves versus that sounds a little more neuromuscular junction versus that sounds a little bit more like muscle. Any particular things on the history that would jump out that would push you to one of those particular localizations?
So time course is one thing. History of trauma is, an obvious one to look for especially for, spinal cord involvement. History of fatigue is one thing I would look for, especially for neuromuscular junction disorders. And then for muscles, I'm not too sure what to look for, but just, muscle tenderness, myositis. Those are certain things that I would ask for to try and rule out, the actual muscle involvement.
Good. So, yep, go ahead. Sorry. Yep.
Yeah, that's about it. That's what I had.
Great. Yeah, so fatigability for myasthenia gravis, right? That's a very helpful clinical sign. The patient feels symptoms are getting worse towards the end of the day, that they're fluctuating. Myasthenia gravis, I don't know the percentage, but almost all patients are going to present with some eye findings as well, ptosis or diplopia, sometimes in isolation, ocular myasthenia, but almost all of them are going to have some eye stuff from the onset, even if there's extremity weakness as well. Lambert-Eaton actually is not fatigable. It's a presynaptic neuromuscular junction disorder. The patients actually get a little better with exercise. They get facilitation. And usually, I've never seen a case of this, so I presume it's pretty uncommon, or I've been missing it. I've only seen cases of it on step 1, step 2, step 3. But patients actually tend to present with proximal weakness, and it's a little bit hard to tell as a first pass that you'd be thinking of the neuromuscular junction. Good, and you mentioned, do patients with myositis have pain in the muscles? They can, although not always. So you can have a muscle disease. If this becomes relevant, there's lots of causes of muscle disease we can get into, and we'll do that deeper dive if it becomes relevant. But many muscle conditions, including some of the inflammatory myositis, for unclear reasons, the patient actually doesn't have pain as a symptom. I saw you were also both unmuted at the same time. Hannah, did you have other things you wanted to put out there for helping us think about if this is truly bilateral symmetric weakness, how to get some clues to spinal cord versus nerve versus neuromuscular junction versus muscle?
Yeah, it may be helpful to explore a bit of family history. There are some autosomal dominant or even autosomal recessive disorders out there. And so if there's family history, that might help pull you in. And then, you can go back through medications and see if, if there are any provoking factors. So a bit more of the sample history might help direct and localize.
Yeah, fantastic. Were there any particular medications that can be neurotoxic and cause weakness that you had in mind, or?
Yeah, any kind of chemotherapy, really. If there's uncontrolled diabetes, I just saw in the chat as well, botulism. So any exposures to cured fish. I just saw that on a practice question, and improperly canned foods.
Yeah, good. So right, chemotherapies can cause peripheral neuropathy. That's one of the most common of the conventional chemotherapies now. With CAR T and immunotherapy, there's all kinds of things that can happen, but Taxols, platins, bortezomib cause axonal neuropathy. So context is going to be helpful. Statins cause a myopathy, right? That could be another clue. Botulism is extremely uncommon thanks to public health measures. Cured fish, I think, is a pretty uncommon. I think it's in Alaska, parts of Canada where it's whale meat or something like this. I've read there's a particular variant of, if I'm not mistaken, botulism you can get from that, but pretty uncommon, except on the boards, right? And they'll usually have a lot of cranial nerve stuff as well. Good. I think things that I'm gonna be listening for to try to help with this differential diagnosis is if this is a spine problem, I'm going to be wondering about sensory problems as well, right? Because the spinal cord is pretty small. You could get a pure motor syndrome, but things like B12 deficiency, you could get subacute combined degeneration. That combined is corticospinal tracts and dorsal column. So is there numbness, paresthesia, sensory ataxia, gait disturbance going along with that weakness? Of course, other time courses could make us think of other things. Transverse myelitis, if it's very sudden. Vivek mentioned trauma. Bowel bladder is something here that would jump out to me, as if it's present, I'd be thinking more about the spine. Doesn't have to be there, but if bowel bladder is not there, I should say we wouldn't expect bowel bladder with peripheral neuromuscular junction or muscle. Just those nerves are super short from the spine to the bladder, so hard to get them in a neuropathy, but spine can cause incontinence, retention, etc. Other things we might be thinking about, is the weakness proximal or is it distal? The classic pattern is proximal weakness, or difficulty brushing the hair, reaching on a shelf, getting out of a chair, going up the stairs for the legs. That makes us think more about a myopathy, a muscle disease. Whereas if we heard about symptoms that began distally in the feet and then made their way up to the ankles, to the shins, and then started affecting the hands, we might think of more about a neuropathy. And again, mixed motor and sensory, that would, of the remaining 3, neuromuscular junction, muscle, right? Shouldn't get any sensory in a muscle disease or neuromuscular junction, but numbness along with that weakness would keep us in the spinal cord or peripheral nerves, right? So those are some things I'll be listening for. And as we've been saying, as Hannah said since the beginning, the time course, right? Because if this happened instantly, right? An instant muscle disease, I don't think so, right? An instant neuromuscular junction disease, botulism is fast, but not that fast. I guess if the patient was bitten by a snake, then you can get really fast. I think that's neuromuscular junction toxicity, though I'm not sure what exactly the snake toxins do. Sudden onset neuropathy, also not really acute neuropathy, sure, for Guillain-Barré, some toxins, etc. So great. So you might say, didn't you say I had a meeting at 10? Why did you spend 20 minutes on the first 4 words? As people know, I like to really unpack these words because they allow us to think about a lot of the general approaches to diagnosis and this particular presentation. And as we're hearing the HPI and the exam, things start to go more quickly because we can see based on things we discussed what direction we're going in. But with Kirtan, I may have miscalculated because sometimes there's a lot of surprises at the end, and we'll see how that goes. Great, so fantastic, Hannah, Vivek, getting us started here. And Kirtan, I'd love to hear the history and then leave it to your discretion whether you want to fill us in on the bottom left corner also.
Sure. So you're already on the right path. We are making good progress here. So talking about the HPI, we have a 52-year-old male who presented with the history of weakness in all limbs, especially right upper limb, for 2 years. It has progressed to the point that he is unable to do any activities using his right limb, with left limb, and by limb I mean upper limb. So he's unable to do any activities using his right upper limb. With his left upper limb, he was able to perform the activities of daily living, but was subsequently unable to continue his job as a mechanic. So he lost his job 6 months back. The patient also endorses 3 months history of shortness of breath. He is, however, able to ambulate properly. So there is no much severe weakness in his legs as per him. Talking about the review of system, the patient denies numbness, tingling, or paresthesias. Patient denies recurrent falls or dizziness. Patient denies headaches, having back pain or neck pain, or any bowel or bladder disturbances. As for the rest of the things, so past medical history, medications, everything is normal. There is nothing there. As for the social history, he used to work as a car mechanic, but he lost his job 6 months back because he was unable to perform the activities of daily living. And as for the allergies, there are no allergies. And that's the end of Aliquot 2.
So just to clarify, Kirtan, this began in the upper limb. It's very severe in the upper limb, but there is weakness now in all 4 limbs.
Yes, that is so. For right upper limb, it was since 2 years. And since last 1.5 years, it moved to left upper limb, because of which he lost his job. And all through the 2 years, weakness is present in the legs, but it's not severe enough that limits him to do his activities of daily living. Yes.
Great. I think you got the first crack last time, Hannah, so we'll give you the first crack. Vivek, here we have a lot of information relevant to some topics we discussed. Feel free to pick any particular individual element or the constellation of elements and let us know what you're thinking at this point.
Sure. So, now we're seeing that there is some sort of localization or lateralization, I guess, to the weakness. Also associated with shortness of breath, not associated with any sort of paresthesia. So going back to what you discussed a little while ago, if there's no paresthesias, no sensory deficit, then we're probably thinking more muscle or neuromuscular junction, or possibly some spinal cord lesion that's, just purely motor in nature. So, going by, the patient's presentation, the age group the age bracket that he falls under, middle-aged male with weakness. There's a couple of things I'm thinking. One of them could be a neuromuscular disease such as myasthenia gravis. Another is possibly ALS. And then apart from that, he did work as a car mechanic. I don't know if that's relevant to his presentation, if there's been any exposures, chronic exposures to some sort of, heavy metals, possible, lead toxicity. I don't know what compounds go in making car batteries or whatever, but that's another thing that I would consider as the possibility of some sort of toxic metabolic process that's affecting him.
Yeah, great thoughts. I realized when I said before, if we had motor and sensory together, that would take off muscle that would take off neuromuscular junction and make us think of neuropathy or spinal cord disease, though we mentioned that you could have a pure motor syndrome in the spinal cord. And I should have mentioned also, of course, you can have a pure motor neuropathy. You can have a pure sensory neuropathy. Also, lots of patients you've seen with diabetes, right, have severe sensory neuropathy without any motor findings. They can have motor without sensory. They can have both. So you mentioned one important cause of motor nerve disease, right, which is ALS, amyotrophic lateral sclerosis, or Lou Gehrig's disease, which is under the larger heading of motor neuron disease, where we have both upper and lower motor neurons affected in the central nervous system and in the periphery. So another thing to think of with pure motor, right, with no sensory. And so as far as neuromuscular junction, just some of the other possibilities here, we didn't really hear about fluctuation. And then, like I said, for myasthenia, you're almost always going to see eye findings from the beginning. And this sounds like a more sort of steadily progressive rather than sort of fluctuating, although diseases can present atypically. And then for muscle diseases, you can get an asymmetric presentation, but for this to be so dramatically asymmetric for so long would be a little atypical. Again, nothing is perfect in medicine, as you know, right? You say sometimes you see a patient with diabetic neuropathy, you know the diabetes is in their whole body, right? And yet one foot, they have a lot of sensory deficits, their reflex is gone, and the other foot is maybe not as bad. It's a little asymmetric, right? Everyone, if you look closely, right, their face is not perfectly symmetric. Nothing is really perfect kind of ink blot, butterfly, perfect symmetry. So possible, but probably a little bit less likely. And then you mentioned the interesting possibility of lead. Again, I don't know as a car mechanic if he would be exposed to lead, but elementary diagnosis, if we're to use that as a clue, lead can cause a peripheral neuropathy, whether it's motor predominant, I'm not sure. I have a vague memory, don't quote me on this, of reading at some point that lead tends to cause radial neuropathies in kids exposed to lead paint, and why it would get one particular nerve in each arm would be a little bit atypical. But gee, if we heard that right upper limb weakness was a wrist drop and he had a radial neuropathy, and we heard this elementary diagnosis makes us think of some element on the periodic table, right? That's something we might keep in mind. And then the other thing that's been highlighted in red here is the shortness of breath. Either of you want to try to work that into this? Yeah, Hannah, go ahead.
Yeah, that jumped out to me because we have a 52-year-old gentleman who's had this chronic and progressive asymmetric weakness, and it seems to be upper extremity predominant. And now all of a sudden we have 3 months of this new shortness of breath. And so the differential to me expands a bit, and we certainly have to include that. So are we now getting diaphragm involvement? Or is he now swallowing poorly and we're getting an aspiration pneumonia? Is this a tumor? So looking more at the, I'd have more questions with the history, but also with physical exam, I'll be really diligent to check cranial nerves and check those, because I do think that this is either a progression of this weakness, or it could be something different, but it's likely that this neuropathy and this weakness is probably also affecting more central structures than just the right arm. So to me, that's a red flag for progression of this disease, and worth exploring for sure.
Yeah, fantastic. First, you gave us a beautiful problem representation, which either Valeria or Maria picked up and put in our upper right corner box there. So thank you for that. Yes, as a 50-year-old gentleman with chronic progressive asymmetric weakness and new onset shortness of breath, and that is a helpful frame, right? Without all of the elements we've discussed, if you just said weakness and shortness of breath, if you're thinking of a condition that's seeming to affect nerves in sequence, where we have one limb and then moving to other limbs, you might say, well, are now the nerves to the diaphragm or to the respiratory muscles innervated by the thoracic cord, cervical and thoracic cord, right? Are those levels now involved? There are muscle diseases, again, I think lower on the differential since we have just one limb involved for so long, but dermatomyositis, we think rash and muscle disease, but can often have interstitial lung disease, mixed connective tissue diseases with myopathy. So a lot of inflammatory muscle diseases have interstitial lung involvement as well. So that would be something else. And then myasthenia, right? Patients with fluctuating weakness in the neuromuscular junctions, that is including the neuromuscular junctions of respiratory muscles. And as you astutely mentioned, Hannah, bulbar muscles as well, right? The muscles controlling swallowing, is this a shortness of breath from respiratory muscle weakness, or has the patient aspirated or something like that? So I think all good thoughts. And I think for me, when I see this, some people call it around the clock kind of weakness, where you have one limb that keeps getting worse and then another limb and then another limb. There's really two possibilities, one more common than the other. This is a relatively common presentation for ALS, where it really starts in one limb and then kind of slowly moves to other limbs. I have one very memorable case of a patient who presented with a foot drop, classic foot drop, and I was in my mind doing that. Is this a perineal neuropathy? Is it a sciatic neuropathy? Is it an L5? Just a little atypically had a little hamstring weakness. And I had to see if a sciatic neuropathy, which is pretty uncommon to get, so that he got something above the knee and not just perineal. So I wasn't really sure, and I sent him for an EMG, and I'll never forget the email from the person who did the EMG came back with a frown on the subject and said, your patient has ALS. I said, what? He's just had a foot drop for 2 years. And I had not taken his shirt off when I examined him, since it was all in the foot. And the next time I said, can you take your shirt off? And there were just fasciculations everywhere. So you can get a sort of unilateral or even one limb presentation that can then kind of migrate so-called around the clock, but it can be very progressive in that one limb early on. There's a bibrachial presentation where the patients present with bilateral arm weakness, and people are thinking, is this some sort of syrinx or cervical spine? But my neuromuscular colleague, when I said, wow, ALS just presenting with foot drop, and he said, in his clinic, the ALS clinic, every patient with foot drop has ALS, the referral bias, right? Whereas the most patients with foot drop, to be clear, do not have ALS, but it's something sort of in the very back of my mind now when I see someone with something that looks like a garden variety neuropathy, a mononeuropathy, that if it doesn't look quite right, to prepare myself, at least in my mind, that the EMG may show something that's not really very benign at all, but fortunately not a common scenario. Then the other thing that can cause this around the clock pattern, which I've only seen once, and that's how I learned about it from a colleague, is a lesion at the cervicomedullary junction. And the anatomy here is just beautiful. The corticospinal tracts cross at the cervicomedullary junction, but if you really want to be a neuro nerd, the arm fibers cross a little bit superior to where the leg fibers cross. And as a result of that, a lesion right at that cervicomedullary junction can cause very interesting patterns of weakness, right? Foramen magnum meningioma, good for you, Kirtan. One of the first neurology CPCs in the New England Journal was one of my mentors. I was probably not even born yet when he did this, but Marty Samuel's doing a CPC of a round-the-clock weakness for cervicomedullary meningioma. And so the idea is that as that lesion grows, it's getting the arm fibers on one side, and then the leg fibers that have already not yet crossed, and then it's sort of going around. You can get all sorts of things there. You can get a triparesis, which is I've never seen, but one arm and both legs, or both arms and one leg, because of these sort of different levels of crossing. I think that's called cruciate paralysis of Bell or something like that, when you have a lesion there, and you can get this around the clock, but that's super uncommon. So could the patient have a lesion at the foramen magnum at the cervicomedullary junction that's causing this very asymmetric thing that's then growing towards the midline, or is this motor neuron disease? I think those are the main things going into the physical exam. So since Vivek, you discussed the history, Hannah, I'll ask you to discuss the exam. I know we haven't heard it yet, but as we go into the exam, given what's on our differential, what are some of the main neuro things you're looking for that are going to help us converge on either a shorter differential diagnosis or a final diagnosis?
Be curious if there's any sensory deficits. I'll be curious again to see cranial nerves and do very thorough there. I'll want to explore more about breathing. But I think it'll be mostly really teasing out strength and sensory. I think will really help.
Yep, I agree with you on all those things. One thing that's not totally clear to us from the history, if we were taking the history from this patient, as Kirtanos would be looking at them and seeing that there's some facial weakness, or there's some dysarthria, or there's some eye movement stuff. We'll be eager to examine it, but we definitely want to see, is this a process that's below the neck exclusively, or above the neck as well, meaning there's cranial nerve involvement, or cranial nerve nuclei, or something at least brainstem and above, which to this point we have no evidence to suggest that there is. Since ALS is something we've all been wondering about here, what would you be looking for in particular on exam there?
ALS classically is motor deficits only with no sensory, so I'd expect sensation to be intact, and I'd also expect a mix of upper motor and lower motor neuron lesions. So you'd expect weakness, you might expect some hyperspasticity, but you'd also expect fasciculations where there's lower motor involvement. So it'd be kind of this mixed picture with ALS. And asymmetric, I wouldn't necessarily expect it to be the same all around.
Fantastic. So a mix of upper and lower motor neuron findings is key to that diagnosis. It can be very striking. You can see a limb that looks very atrophied with fasciculations, and yet you get brisk reflexes there. And so particularly in this right arm that's been most affected, we'll want to see, is this an exclusively lower motor neuron process, upper motor neuron, or a mix? And then, as you said, looking at other limbs that may not be affected, this mix of findings. We never want to give that diagnosis of ALS because it's a very devastating diagnosis to give, and the prognosis is pretty bleak. There are some new treatments, but they're sort of just prolonging time to ventilator by months. And so this is a very sad diagnosis to make. And we want to make sure, since we can do an EMG study and try to look for evidence, but there's no sort of blood biomarker, CSF biomarker, et cetera. So there are a couple of things we really want to rule out and make sure are, or treatable etiologies that could mimic this. Either of you know, Hannah or Rebecca, let me focus that a little bit. What's something else that could cause chronically progressive weakness with a mix of upper and lower motor neuron findings that might be a little bit asymmetric and become more symmetric as far as localization? And something that's one of the main rule outs when we see, oh, this patient has weakness in all the limbs, sort of asymmetric, there's upper and lower motor neuron findings. I hope it's not ALS, something that would actually be a good diagnosis to make. I mean, never want to diagnose a patient with the disease, but a treatable, reversible one. I know it's a little bit guess what I'm thinking, but anyone know what you might be thinking of here?
I'm actually thinking maybe of one of the forms of multiple sclerosis, because, the most common one is the recurrent relapsing one, but there's also, the primary progressive form of multiple sclerosis where they may not have those gaps in between episodes. So that's one thing that I want to rule out.
Okay, progressive multiple sclerosis, you're right. Usually we see relapsing remitting, which can later morph or evolve into a sort of secondary progressive. Every once in a while, there's a primary progressive, and that tends to be more of a spinal variant or a spinal sort of focused disease. So that patient could present with progressive weakness. Probably they're going to have bowel bladder, sensory, other things, and shouldn't have any lower motor neuron findings, right, as that's a CNS disease. Anything else on that you were thinking of? Could cause weakness below the neck, arms and legs, asymmetric, plus minus sensory, but with both upper and lower motor neuron findings.
I can't think of anything. I could pass it to Hannah if she's got any.
Yeah.
Potentially a mass, but multiple sclerosis is my guess for the biggest.
You're thinking that also. Yeah.
But
you said a mass. Where would you put that mass to give you upper and lower motor neuron findings? Let's see if I can.
Spinal cord.
Yeah. So that's exactly right. So the spinal cord, we think, oh, it's the upper motor neurons going down, right? But it also has the lower motor neurons coming out. So one thing that can look a lot like ALS, and we are glad when we see it and it's not ALS, is just good old-fashioned cervical spondylosis, right? So if the patient has progressive compressive osteoarthritis or other, patient with rheumatoid arthritis has pannus or something up there, compressing the spinal cord, you'll get the upper motor neurons on the way down. So you can see upper motor neuron signs below the level of the lesion, but you're also getting the roots and the lower motor neurons on the way out, right? So if you think of a tree with the branches coming out, right, you're getting the, whatever it is, the xylem and phloem that go up and down, right? Those are the upper motor neurons on the way down, but you're also getting the branches on the way out. So you could get a picture that could look like this. Maybe I'm still wondering about Kirtan's title. An elementary diagnosis, maybe it's not an element, but just something that's very common and mundane. One of the first neuro VMRs I did, they presented a case with myoclonus of one arm. And it was a very rare presentation of just cervical spondylosis. And for whatever reason, the compression of the cord caused myoclonus in one limb. And it was a common disease causing a rare presentation. So whenever we're thinking about ALS, I had a patient recently that almost certainly has ALS, has had cervical imaging within the last few years that look fine. The person who did the EMG said it's probably what it is, but just do one more cervical MRI to make sure we're not missing something sort of mundane and treatable, just compressive disease. So, so that's something to think about. Something else we look for with a pure motor syndrome that is more treatable than ALS is something called multifocal motor neuropathy, super rare. I've never seen a case that's a variant of CIDP, the chronic cousin of Guillain-Barré, chronic immune demyelinating polyradiculoneuropathy, CIDP, as opposed to AIDP, the Guillain-Barré. So that's a chronic neuropathy, which can be sensory motor, can be sensory, and then rarely can be this multifocal motor neuropathy, which presents with weakness in one limb, then another limb. And those patients will have conduction block on their nerve conduction studies, as patients with ALS will not. Most patients can respond to immunomodulatory therapy, though not as well as other CIDP variants. So I think we're going to be looking for upper and lower motor neuron signs here, and then maybe some other clues here, but we may just be left with what we know, that this patient is weak, has either all lower, all upper motor neuron signs, or a mix. And we'll be thinking about what the next studies are to make a final diagnosis, and wrestling with how to use whatever clues Kirtan has put in his title for us. Is lead poisoning still on the table? I guess it could be, if we want to weight the title in our reasoning here, and it's an element. Okay, Kirtan, what did you find on the physical exam?
Sure. So as for the vital signs, the temperature, heart rate, and blood pressure are all right. As for the SpO2, it was 95% on room air, and the respiratory rate was normal with 18 breaths per minute. As for the general appearance, he appeared well and was conversant. There was no evidence of any confusion there. Abdominal examination, CVS, pulmonary, all good, nothing there. As for the neurological examination, again, the mental status, patient was alert and oriented to time, place, and person. The cranial nerve examination was normal. There was no evidence of any cranial nerve palsies. The sensory examination was normal. And then, for the motor examination, in the right upper limb, it was +2 out of 5 distally. So the power was +2 of 5 distally, +3 out of 5 proximally. In the left upper limb, it was +3/5 throughout. In the left lower limb as well as the right lower limb, so in the both the lower extremities, it was +4 out of 5. There was impairment of fine motility of both the hands. There was moderate to severe weakness on bilateral grip strength test. There was evidence of atrophy of the interosseous muscles of the right hand. There was right thinner atrophy. There was atrophy of the triceps and biceps muscle on the right side. On the left side, there was evidence of interosseous muscle atrophy, but there was no evidence of biceps and triceps atrophy. The Hoffman sign was positive bilaterally. There were no visible fasciculations. And as for the reflexes, they were normal in upper limbs and they were brisk at the knees. However, plantar reflexes were normal, so they were downgoing plantars bilaterally. So Babinski sign was negative. Just to repeat that, so the reflexes were normal in both the upper limbs and they were brisk at both the knees. As for the meningeal signs, they were absent, higher functioning was normal. And the basic metabolic panel, including the hemoglobin, WBC, basic metabolic panel, apart from hemoglobin, like LFTs, RFTs, serum lactate, LDH, all was normal. CRP and ESR was also normal. And I guess maybe I can give a little more left findings or I can wait, yeah.
Yeah, okay, very good. Fantastic. Okay, Hannah, we went into this exam with some hypotheses. We have tested them. What are you thinking here based on this? And if you know what the Hoffman sign is and want to tell us about it, that's fantastic. If you don't, no worries. We will discuss it.
No, that was going to be my first question. I don't actually know what the Hoffman sign is.
What is the Hoffman sign, Kirtan?
Well, it's just a sign which you can use to check the possibility of upper motor neuron lesion, just like Babinski sign. And it's difficult to explain how to elicit that, because you have to use your thumb, use your fingers, and do that delicate maneuver there. But basically, if it is present, then you can be assured of the fact that there is at least some degree of upper motor neuron involvement.
Yeah, so this is like the Babinski sign for the upper limb. So you take the patient's hand in your hand and you sort of snap your fingers. I guess I would, I'm trying to think what I would do with my both hands, but you sort of snap your fingers on the middle finger, and a positive sign is that the fingers and the thumb will flex. You can see this with mundane cervical spondylosis. So if you see it, you don't have to, ring the alarm bells. if it's a patient who is older and might be at risk for that condition. But it's sort of a Babinski of the hand, the Hoffman sign. You snap sort of over the middle finger, and the thumb flexes and the fingers flex. So that is an upper motor neuron sign. Okay, go ahead, Hannah. What did you make of this exam?
Okay, so we see that mental status is normal. So it's looking like it's not supratentorial. We're seeing cranial nerves are also normal. So it looks like less likely to be a brainstem involvement. We're seeing that sensation is normal in all limbs. And so that was a big branch point in our hypothesis. Looking like reflexes now, we have some stuff to tease out. So Hoffman negative is saying there's not upper motor neuron lesion in the upper extremities.
Was Hoffman's negative, Kirtan? So sorry to interrupt you. Was Hoffman's negative, or it was present, Kirtan?
It was present. It was present.
Oh, it was present?
Okay. Present. Sorry, I know you said, I thought I heard that, but it didn't make it into the right. Sorry to interrupt you, Hannah, but wanted to make sure you were playing with all the elements, no pun intended, on the table. Yeah, Hoffman's positive. Okay.
That is indeed a very important distinction. So now it looks like there is definitely an upper motor neuron lesion for the upper extremities. Babinski was negative, so not necessarily upper motor neuron for lower extremities. We have that mixed picture, which we were kind of seeing with the presentation anyway. However, brisk reflexes in the lower extremity, which looks a bit more like upper motor neuron, normal reflexes in the upper extremity. So that is definitely a mixed picture from the reflexes standpoint. And then with motor, we're seeing this, we're seeing distal more than proximal weakness in the right upper extremity with atrophy. And then we also see atrophy predominantly in this hand. So most of those muscles are actually, and the nerves are more proximal. So it kind of localizes a bit more proximally than just a local hand lesion as well, or neuropathy there, like the wrist or some other compressive situation. And we're also seeing on the left. So this is not a very clean picture. We're seeing weakness, we're seeing atrophy, we're seeing in the setting of also upper motor neuron lesions for upper extremity, and then also a mixed picture with lower. So it's a mess, but sensation's intact, and mental status is intact. So to me, this looks potentially a bit more ALS, like it's that mixed picture, sensation intact. And then I still don't have a really good answer as to what is causing the shortness of breath. The vitals looks non-toxic, 95% on room air. I'm not terribly offended by work of breathing, appears to be okay. And since in the cranial nerves are normal, so I don't have a really good explanation yet as to why there's the shortness of breath.
Yeah, great thoughts, Hannah. There's a lot of information there, and you synthesized it beautifully. Things that jump out, right? That there's one limb that's much weaker and much more atrophied than the others, and it doesn't appear to respect the territory of a particular nerve. This isn't a wrist drop from a radial neuropathy or intrinsic hand muscle weakness from an ulnar neuropathy. You could, I guess, zooming out, say this patient has multiple kind of areas of weakness in multiple places. Do they have a mononeuropathy multiplex, which is almost always mononeuritis? Multiplex as a cause, that's usually painful, and these are nerve infarcts, so usually sudden, but I guess something that we didn't mention that we can throw out there and then remove from our discussion. But when you see a limb that's that atrophied and then actually find a normal reflex there, that's not a normal reflex, right? There, if the limb has that much lower motor neuron dysfunction, that much weakness, that much atrophy, the fact that the reflex is normal, I think, is almost sort of, it's brisker than it should be, because it should be absent, right? So I agree with you. We have a mix of upper and lower motor neuron signs here, asymmetric weakness. I think ALS remains high on the differential. Cervical spondylosis, as I said, is always a rule out in these patients. And could this patient have very asymmetric spondylosis or meningioma, or, as you mentioned, Hannah, a tumor, something sort of pushing on the cord that's sort of been pushing from one side there on the right, and then eventually has started to affect the entire cord as the cord has gotten sort of pushed against the dura on the other side. So I think the spine is still on the list. I can't think of any elements that would cause this. For instance, I saw manganese fly by in the chat. That actually usually causes Parkinsonism, which we don't see here. And then another super rare rule out for ALS, when the arms are very predominantly affected and very atrophied in a particular pattern where I think it's mostly forearm atrophy out of proportion, if I'm not mistaken, is called Hirayama diseases. Is a super rare condition. I've seen one case and heard about one case, which is an interesting condition whereby there's some, I forget what the actual anatomy physiology is, but that when the neck is in flexion, the anterior portion of the cord gets pressed against the dura. So actually, if you do a cervical MRI, it will be normal. But if you actually have the patient flex in the MRI and do the MRI, you'll see that the cord is getting, the anterior cord is getting compressed. And these patients can have symmetric or asymmetric severe upper extremity atrophy and can actually be treated just with a cervical collar, and they can get much better. So that would be something, again, which we must more hopeful diagnosis than ALS. It's called Hirayama disease. I think it was just discovered by Hirayama. I don't believe it has a particular predilection to any part of the world, but I could be wrong about that. It may be inherited. I could be wrong about that. Anyway, something just for gourmet neurology to put on the list. But I think ALS and cervical spine are sort of our top differential diagnoses. So Hannah and Vivek, Kirtan was about to tell us some studies here. What are the studies you would want to get at this point to try to make a final diagnosis?
So we already have this labs and they're not telling us much. I'd probably follow up with some imaging, get an MRI of the spine, MRI possibly of the brain, although we're not primarily suspecting the brain to be involved, just as a rule out. Definitely get EMG and nerve conduction studies. And apart from that, I don't know if spinal tap is indicated at this time, since we're not suspecting any sort of infectious or viral etiologies. But that might be another thing to consider if the other two are, non-significant. But for me, mainly my two primary concerns would be getting an MRI and getting EMG and CP for this patient.
Exactly, right. So we definitely want an MRI, and if we had to focus on one area, as you said, we choose the cervical spine. There's nothing really pointing at brain here for us, again, to have bilateral asymmetric brain lesions, and the patient has getting the motor areas, but no sensory right behind, no cognitive stuff progressing forward in the frontal lobes, right? This seems to be cervical spine or below. So we definitely want to look there and see if there's a lesion there, and if there's not, and the cervical spine looks normal, unfortunately, we're out in the motor nerves and our differential gets pretty short, and we would use EMG nerve conduction studies to try to prove that there are the findings you'd expect to see in ALS. We have some upper motor neuron signs on exam, and we'd be looking at proving that there is lower motor neuron, isolated motor neuron dysfunction through the signals we can see on nerve conduction and EMG. And there are criteria about having to have a certain amount of, I forget what they are, I think they're called the L-Escorial criteria of having findings that are above versus below one level, because again, you could see a patient with cervical spondylosis who has lower motor neuron findings only in the arms and upper motor neuron findings in the legs. And they could look like they have mixed upper and lower and they have weakness, but they wouldn't meet criteria because the upper motor neuron signs are below the lower motor neuron signs or something like that. I'm not an ALS specialist, but something like that. Okay, Kirtan, can we hear about those tests? Are there any labs or CSF, as you said, Vivek? Not that I can think of. I think muscle disease is way off the list now. A CK maybe earlier on would have been something we would have thought about, but I think serum labs are not going to be super helpful. It's really the imaging and the neurophysiology that's going to help us. And I don't think we're getting hints at an infectious or inflammatory cause here. So I think we're between ALS and something in the cervical spine, and then we come back to our elementary diagnosis. I can't sort of make a word association with elementary and ALS, though I'm not as clever as Kirtan. And an elementary diagnosis here, and one that would be good news for the patient, is whether there's just good old-fashioned cervical spondylosis. There is a mechanic, does a lot of work, hunched over maybe, and has some bone spur osteophyte up there that can be taken care of surgically. A tumor there, as Hannah mentioned, also some indolent meningioma, something like that, I think, on the list, but relatively uncommon. Okay, Kirtan, what did you and your colleagues do next, and what did you find? And we're eager to hear both the diagnosis, unless you have several more aliquots, we'll deal with them, and how this relates back to your title.
Yes, sure. So for the sake of time, I will do it in the single aliquot. So first we got the vitamin B12, folate, copper, zinc, vitamin E levels, just to make sure that myelopathy was something not we are dealing with. So all of them were normal. We get the HIV and syphilis serologies. They were also normal. As for the EMG, there was evidence of widespread fasciculations, suggestive of active, severe chronic denervation with incomplete re-innervation affecting the muscles of cervical dermatome much more than the lumbosacral and thoracic dermatome. As for the nerve conduction studies, both the motor and sensory nerve conductions were normal in all the extremities. And now about the final aliquot and the final diagnostic test that we did. So you were right, actually.
Just pause there.
Yes, sure.
So
Yes.
EMG and nerve conduction, that's a, we won't dive deep there with just a few minutes left, but sensory and motor nerve conduction studies are normal here, right? Although we saw signs of innervation, denervation, renervation. This is a really hard question and I can answer it, but any thoughts on how it could be that you're looking at electrical flow in the nerves and it's fine, but you're still seeing evidence in the muscle that nerves have been innervated, denervated and renervated? How could that happen? So the answer is that this is problems in the roots, right? So when you're doing an EMG, when you're doing a nerve conduction study, basically you're just using the nerve as a piece of inert wire and you're just sending electricity up or down it, even if that's not the direction the current would flow in nerve impulses. And you're looking at the time, you're measuring the distance and you're getting the velocity and you're looking at the amplitude. So if that all looks fine, and yet the muscle is showing you through the EMG, you put a needle in there and it has different patterns, fasciculations, fibrillations, positive sharp waves, all these things that show you, hey, the relationship between the muscle and the nerve is not normal. That tells you that maybe something was happening at the root level or the cell body level, very proximally, that you can't detect because you can only do the nerve where you can see it, right? And there are other things you can look at, the F wave, the H reflex, that allow you to send impulses up and back down and look at those. But the fact that we get normal motor conduction on all our motor nerves means this is not ALS. This is good news for this patient, right? And so I think we're back to the cervical spine here, right? And this may be, as we've discussed, a case where everything sort of looks like ALS, but it's good news for the patient. We find something amenable to treatment, maybe an elementary diagnosis of cervical spondylosis in the cervical spine. So I suspect this last aliquot is a cervical MRI, and if elementary means what I think it is, maybe it's just a benign mundane cervical spondylosis. What did you find, Kirtan, when you looked at this gentleman's spinal cord?
Yes, sure. So you deciphered. So yes, you deciphered it correctly. It was actually elementary in sense that it's so easy that we shouldn't miss it. Rather than going for $1 million workup, we should order this first. So MRI of spine was obtained, and there was evidence of posterocentral, bilateral, paracentral, and foraminal disc osteophyte complexes at the C5 to C8 level, causing indentation over the ventral aspect of spinal cord and narrowing of the bilateral neuroforamina with compression of the bilateral C7 root. There was focal T2 weight hyperintensity in the cervical spinal cord at C5 to C6 level on the right side, suggesting the possibility of myelomalacia from chronic compression. And yes, so you are right, the final diagnosis of cervical myelopathy, to be specific, cervical myelopathy presenting as DML, that is dissociated motor loss. So basically in DML, what happens? There is isolated intradural compression of the motor roots, and hence we get sparing of all the sensory roots, and hence no bowel and bladder problems there. And furthermore, the presence of LMN signs in the upper limb and the UMN signs in lower limb, coupled with the lack of any bulbar symptoms, was less consistent with ALS. And yes, we even considered the possibility of Hiriyama, but given the fact that Hiriyama usually occurs in young patients, and furthermore, the patient was so claustrophobic that we were unable to convince the patient to again go to MRI to do the flexion T2 sequences. So unfortunately, we were unable to do that. But after this diagnosis, the patient was referred to orthopedics department and surgery department. They did some surgeries. I'm not sure about what they did, but in the end, the patient actually stopped progressing. So he never recovered the muscle that he lost, but he was able to return to his job as mechanic. So it was actually, good for the patient in the end. and all of you discussed it amazingly, and even the chat got it very early on that it could be cervical spondylosis, and even you got it halfway along. So as I told you, it's a simple case, and today you will be there at 10 o'clock for sure, Dr. Berkowitz.
One last thing, Hannah mentioned that we weren't sure of that to do with that shortness of breath, and I was going to mention at that time and then ask you, Kirtan, the explanation. For neurology, if the patient's hypoxic, in medicine, this is a very common thing that you all worry about. Our patients aren't usually getting hypoxic, they're getting hypercarbic, right? Because they can't, either they have a depressed level of consciousness and they're hypoventilating, or they have restriction of the chest wall or neuromuscular weakness, right? And they're retaining. So for us, the idea that the SATs are normal and the patient's short of breath on the neurology side is often concerning. And one thing we'll do as a fun bedside test, if you haven't heard of this, I say fun because it's fun to think about. It's obviously not fun if you're having to test a patient for this, but for neuromuscular weakness in particular, a rough measure of the vital capacity is you have a patient take as deep a breath as possible and count at a normal pace as high as they can go. And every 10 or so is about a liter of vital capacity. So if you try this yourself now, right now, you take a huge deep breath. It's very hard to get patients to do this. They'll 1, 2, 3, 4, 5, 6. You really need 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, and etc. So if a patient has, can get to 30 or 40 or 50 on one breath, we're reassured. And if they're in the 10, 20 range, it's a rough measure for vital capacity. So was the thinking here, Kirtan, that the cervical spondylosis was so bad and so superior up to the C5 level that there was some diaphragmatic weakness here, or some chest wall muscle weakness from some thoracic, or what was the thinking on the shortness of breath? Because that's definitely something early on that would have made us think more about ALS, right? Shortness of breath from cervical spondylosis would be a pretty uncommon presentation.
Yeah, sure. So you are on the right path. So actually the C5 to C8 indentation was there. So the neurology department thought that it may be attributed to bilateral what is that name? Phrenic nerve. Yeah, phrenic nerve involvement was there. And that's why the diaphragm was not able to move. And it was not something so severe that you can see it on the X-ray as hyperinflation. But definitely there was evidence of phrenic nerve involvement because of the severe myelomalacia and indentation all the way up from C5 to C8.
Got it. Thank you for clarifying that element. And just a couple of things, then I'll leave Valeria to her teaching points. One is that once you see cord signal change, some people believe that the likelihood of surgery causing reversal of deficit is a little bit lower, though as Kirtan said, we want to prevent this from progressing. The patient can still use his left arm and legs here, though once the right arm is that atrophied, not clear that we're going to get much recovery from surgery. The other thing is this has been recently described, you can get enhancement in the cervical spine from compression. Usually if you see enhancement in the spinal cord, you're thinking inflammation, tumor. Recently described that you can get this pancake sign where it's sort of at the level of the compression or just below it, or maybe it's just above, or maybe it's either. It just looks like a pancake, a sort of line or sort of stripe of enhancement. And that's a very typical sign. I don't believe it has any prognostic value, but this was recently described by the spine group at Mayo. Recently, as in, within the last couple of years. And so not all enhancement in the spinal cord means something sinister. So just something to keep in mind. Okay, I do have to get to my meeting. Thank you, everyone, for allowing me to escape a little bit here. I apologize. I'd love to hear Valeria's brilliant teaching points, but I'll look forward to reading them. And just want to thank Kirtan for bringing this fantastic case. You said it was simple. It was a mundane diagnosis, but it was a complicated case and allowed for a lot of great discussion. And Vivek and Hannah, brilliant discussion working through this case and sort of narrowing our differential as we went. So thank you all very much. I'm going to make you the host, Valeria, and I apologize that I have to duck out a little early, but everyone else, the other 30 people here, hope you saw how much fun that was, and you'll be excited to participate next Tuesday. Thanks again, Kirtan, Hannah, Vivek, great job. I'll see you again next week.
Thank you, Aaron. Okay, so to finish with the teaching points, thank you so much, Kirtan, for this case. It was amazing, and the discussion as well. So we started with a chief concern, which was generalized weakness. And so the first thing we need to remember is that it could be true weakness or not. And so we should rule it out first asthenia as a possibility. Then the chat mentioned causes that could be classified as neurological causes versus non-neurological causes, that even though it is Neuro VMR, we should not, or we should still keep in mind, like endocrinopathies, diabetes, polymyositis, and electrolyte disturbances. And then, as always, the neurodiagnosis equation is time course and localization. And so starting with things, we didn't have a lot of information at the start, so possibilities of hyperacute, something vascular affecting, for example, bilateral cortical or cortical areas that could be less likely, but still must be in the differential, or something like that lock-in syndrome that could affect the brainstem and could also cause generalized paralysis. Also in the hyperacute category, stuff like seizures and metabolic and drugs and toxins are actually part of every time course possibility. And then thinking about history of trauma. And then in the acute time course, thinking about usually infections such as bacteria and viral infections as well, inflammatory causes such as Guillain-Barré syndrome, and demyelinating diseases. And in the subacute and chronic buckets, stuff like malignancy, inflammatory as well, demyelinating, which was also part of our ALS mimickers, such as CIDP, paraneoplastic diseases, and as well as metabolic and infectious such as fungi and parasites. And then in the localization part of the equation, we should differentiate between symmetric and asymmetric causes, and also collecting clues from the exam, thinking about cranial nerve involvement, just to differentiate between above the neck and below the neck. And then just reminded us of the track of the motor track, and starting in the bilateral cortical, which would be less likely, but still a possibility because it is a generalized weakness. So it's not very like precise in the homunculus. And then going down with the corona radiata, the brainstem, the spinal cord, the roots, the nerves, the possibility of polyneuropathy was early on in our differential, such as vitamin deficiency and myasthenia, just because of the title of the case as well. And then thinking about neuromuscular junction and finishing with muscle. And then Aaron pointed out the fact that we should start thinking about collecting clues from the physical exam and thinking about myasthenia. It usually presents with eye compromise, fatigability, and then also keep in mind common causes being common, history of trauma, and also Hannah was very, very good that she pointed out the chemotherapy medicines as a possibility. Then also thinking about mononeuritis multiplex that usually presents with pain, and so thinking that it's just a generalized weakness, also sensory involvement, and the possibility of botulism if the patient had some exposure to fish or honey. And then also autonomic involvement, just to localize to the spine, usually if there's bladder or incontinence, and also differentiate weakness in the muscle side, thinking about proximal weakness that usually will most likely suggest a myopathy versus distal weakness, which usually is more characteristic of a neuropathy. And then also Hannah mentioned that mixed signs of upper motor neuron and lower motor neuron lesions are usually characteristic of ALS. And as the case progressed, we had a problem representation of a patient presented with asymmetric chronic isolated weakness. And in that case, ALS was top of our differential, thinking also about myasthenia and lead exposure, just because we thought that it was an element in the case. But then also the fact that the patient had shortness of breath made us think that this could be a polyneuropathy progressing and compromising the respiratory muscles, or also a myositis, and thinking about myasthenia as well. And then Aaron mentioned the two main causes of around-the-clock weakness, starting from a limb and then progressing to other parts of the body, such as ALS and a lesion compromising the cervical-medullary junction, such as Bell's cruciate paralysis. And then we finish with an ALS mimickers, like the case in today, which was cervical spondylitis. And so, and Kushal also mentioned in the chat the possibility of West Nile virus causing polio and CIDP and Hirayama disease, which is most common in young males, and is an insidious asymmetric atrophic weakness that usually compromises the forearms and the hands because there's a forward displacement of the posterior dura of the lower cervical canal that also usually happens in neck flexion, and this is how it is diagnosed. And then we gave the final diagnosis with the EMG that ruled out ALS, and Aaron pointed out that if the EMG is normal in the nerve findings but abnormal in the muscles, I'm sorry, with the typo, we should think something compromising that neuromuscular junction. And so thank you so much for attending today. I hope to see you all tomorrow. Have a good day.